Hello guys, how are you? I hope that you are doing well, that you are enjoying this weekend. It's not as beautiful as last weekend, but I hope that you are doing something good with this time that we are experiencing. All right, so today we're gonna finish what was left, which is OCD and PTSD, two very interesting disorders. PTSD, by the way, is my favorite disorder in the sense that I struggle with PTSD. And then I did my PhD in PTSD, evidence-based treatments and post-traumatic growth. So I hope that we can have something interesting from this class. But before doing that, I want to share with you something that I found yesterday, and I really like it. And I thought, I need to share this with my students. So this is a podcast that by Dr. Scott Barry Kaufman, that it's known the Psychology Podcast. You should have the link in the resources document that I shared with you guys at the beginning of the semester. There's a bunch of podcasts there that I suggest you to go and pay attention, but this one is very good. By the way, this Dr. Scott Barry Kaufman, he's also the author of a book that is called Transcendent. And it's, I will say it's like Abraham Maslow 2.0, okay? He is bringing Maslow's theory up to date and including all the research that has been done and so on. So it's a humanist scientist, okay? That's how I will talk about him. He's very connected with the positive psychology field of study and so on. And then he had this guy in his podcast. His name is Adam Grant. He's also a psychologist, but he's a psychologist that works in organizations, okay? So he's an organizational psychologist, but he's very smart guy. They both do a lot of research. They both are professors. They both know the field of psychology very well. And Adam Grant has this book that it's titled Think Again. I haven't read the book, I need to tell you that, but after the interview, I will definitely read the book because I think it's very interesting what he's presenting there. And I just want to share with you a couple of ideas and encourage you to go download the podcast and listen to this episode. So Adam Grant says that we have 4 different ways of thinking. And this, I think that it was very clever. He says, one is the preacher, the other one is the prosecutor, the other one is the politician, and the other one is the scientist. And of course, he says the 3 first, it's not a very good idea to engage in that way of thinking because what's going to happen is that we're going to have negative results, right? So the preacher is when you think that you have the truth, right? That you have the knowledge of what is truth, and then you're gonna go and preach that truth to others so that others can convert. Now the prosecutor, I think this is very interesting because we are seeing this growing and growing like a trend in our current society, right? Is when you have this set of mind where you are thinking, not only I have the truth, but I also need to condemn those who don't have the truth. I need to prosecute them. I need to go against them, and I need to show them that they are wrong and I am right. And therefore, I'm going to do everything in my power to let them know that, and to silence them or to remove them or to so that I can show them that I am the one that is right. And he's like, well, that's not a good way to go because that's the formula to have on one hand conflicts, but on the other hand, he says, is the formula for you to not to grow, right? And he's talking about these 3, the preacher, the prosecutor, the politician, in that sense, that they are not allowing us to have a real learning, growing process, I will say something like that, okay? And then the politician, he says like, well, here is different. Here is when you show yourself charismatic and you try to be nice with others, especially with those who think like you, and then others can praise you and say like, oh, what a great person you are, what a great job you are doing, right? And he's like, but that's just an echo chamber. That's not helping you neither. So he says, what's the solution? The solution is the scientist. And he says, we can develop this way of thinking. And here It's pretty much what CBT has been saying for the last 30 years. We need to help our clients to develop a scientific mind, a mind that is based on hypothesis and hypothesis testing, right? I have ideas, and these ideas might be right, might be wrong. I don't know. I'm going to test them. I'm going to look for the data. I'm going to listen to other ideas. I'm going to be open in regards of in not defending my ideas, but being open in listening others' ideas and see if I can complement them or not, if I am right or I am wrong. And I think this is a beautiful way of putting it, because one of the things that Marcus Aurelius was saying is that he was, his commitment was with truth. So if there's anyone who can show me that I'm not in truth, please do it, because then I'm going to be happy to receive that, right? So it's this attitude of openness in life. By the way, the 5 big theory, I don't know if you know that, but if you don't know it, you need to know it, okay? The big 5 personality traits is a very, very important theory in our field. And one of those traits is openness, right? And openness means I need to be open to learn new knowledge, to listen to other ideas, and to understand people have different ideas than me. And that's okay, because no one has absolute knowledge of truth, right? We are all trying to understand what is truth, and therefore, the more that we are open, the more that we can understand that other people may have different opinions than us, and we can try to listen those opinions and see what is true, what is not true on those opinions, the more we're gonna grow as a person. Then they talk about how these two concepts that I consider very interesting. One is relationship conflict, and the other one is task conflict. And he says, when you're in preacher, prosecutor, or politician, it's more likely that you're going to engage in relationship conflict, because you're going to see others as your adversaries, as people that they are wrong, as people that they are mean, bad, or whatever, and then you're going to try to do something with that people. And they say, but the solution is to think about task conflict. And that is, okay, here we have topics, tasks, we have ideas, and if we have a conflict in our ideas, that's okay, because that's how we can grow. I can do more research, I can try to understand you better, I can try to see where are you coming from, and try to have a deeper understanding of the situation. I really like that too. Then they talk about, and this is the last thing that I'm going to share about them, because I want you to go. I don't want to do a spoiler alert here, right? But they talk about safe spaces versus psychological safe. And they say safe spaces, this trend in our culture now, that there should be places where people shouldn't be offended, people shouldn't listen things that they don't want to listen, people shouldn't receive comments that are different from their own ideas because they can feel hurt, right? They say, well, that's a formula to stay there forever. That's a formula for you to not to grow. Because if you don't listen other people with other ideas, with other positions in life, how are you going to grow? Then say, the solution for that, or the alternative, is what we call psychological safe. And what is this psychological safe concept? What they are saying is precisely that we are going to make you strong, and that we are going to make you strong so you can engage in conversations, that you can listen to other people, that you can listen ideas that are different from yours, and that you can see if there's something that you can learn from there or not. And they say that's what we do with our kids. That's what we need to do with our students in college. That's what we need to do in our society, to help people to understand that everyone comes from different places, and that because we come from different places, we have different opinions, different ideas, different understanding. And the more that we listen to each other, the more that we are open to understand the other person's position, the more we're going to learn, and we're going to be okay with that. And finally, they talk about seeking perspective. And this I really like it because it's not the um, um, taking perspective that we are more used to listen that concept, but this is seeking perspective. And what they are saying is like, now I'm going to try to understand from your point of view, why is that you see things in this way? Where are you coming from? So I can understand why you see things in this way. So for example, if you have an encounter with someone that has a different political opinion than you, has a different religious opinion than you, and instead of jumping and say like, he's wrong, she's wrong, he shouldn't say that, that's bad, maybe better to say like, okay, tell me more about you. Let me understand why is that you have those ideas. And then I can be able to understand from your perspective, why is that you think in that way without condemnation. And they talk about an example that they did a research, and this was about guns rights and guns control, right? And what they did is that they asked the people that they were supporting guns control, and the people who were supporting guns right, they asked them to imagine that they were born in different places and see what would be their opinion. So for example, for those who are pro-gun right, gun rights, they say like, okay, imagine that you were born in Columbine, and imagine that you grow up in the aftermath of the shooting in Columbine, and that you saw your friends, your families, and so on die, and also struggle with the death of their loved ones, and so on. Maybe you even struggle with the death of one close loved one. Would you be more open to work in the, would you be more open or willing to consider guns control? And most of them says, yes, I will. And then they go with the others and they say, okay, you are gun control, but what we want you is to imagine that you are not this person, but you are a different person. You were born in a family of hunters. Your dad is a hunter, your siblings are hunters, your grandpa is a hunter, and there's a whole family tradition of hunters. And you grow up with guns, you grow up hunting, and you were bringing food to the table for that hunting, and so on. Now, from that perspective, would you understand why they are trying to protect their guns right? Now, would you be more willing to see that maybe there's something that they have to say in the gun rights movement? And most people say, yes, absolutely. So this is the perspective seeking or seeking, perspective seeking, right? That they were talking about. And I really like it because I was thinking in our clients, many of our clients, they will come with their own situations, ideas, problematics. And instead of trying to judge them from our perspective, from our mindset, we should try to have this, cultivate this perspective seeking, trying to, perspective seeking, and trying to understand why is that they grow up in that way, why is that they have that type of understanding in their life, and how can we, without judgment, understand them better and see what is good and what is not doing good to them and helping them to do the change. All right, so no more about this podcast. I hope that you like it. It's really good. And yeah, maybe you're gonna like it. And this guy, Scott Berry, he has interviews with pretty much all the important people in the field of psychology right now. So he has done a very good job there. He's peculiar. You will see he has a peculiar personality, but maybe we all have peculiar personalities, right? All right. Well, let's go with talk about obsessive compulsive disorder and PTSD, guys. Okay, let me open that for you. I'm working on that. And oopa, I'm sorry, it's not this one. Um, now we have it. Okay, sorry, I apologize for that. I have been in a hurry because I have a meeting at 12 and then it's 11:12, so I don't have that much time. But okay, let me share my screen with you. I have it now. And this is what we were talking about, our previous class, anxiety and stressor related problems. Okay, so, and let's go here. Okay, obsessive compulsive disorder. I don't know if you watched this movie or not. If you haven't, go and watch the movie. Now you might like or not the thriller of the movie, but the reason of why I'm suggesting you this movie is because Nicolas Cage. I really like him. He has great performance in some movies, but then he has other movies that I didn't like it. Um, I guess that those where he tries to be like a tough guy with like a, I don't know, like more action movies. I didn't like those that much. But then he has another one that is called Living Las Vegas, I guess. He did a great performance there as well. But this one for me is his best performance. And he is characterizing a client with OCD, okay? And the way that he represents a person with OCD is so accurate that I think that it will be good for you to go and watch it. Now I'm not going to tell you the rest of the story so you can learn, but you're going to also see some elements about the treatment for OCD and the psychological element of the treatment. And yeah, I don't know. Okay, I hope that you like it. Maybe you can share with me your thoughts about it. So what is the DSM telling us about OCD? First is the presence of obsessions, compulsions, or both, okay? Now, obsessions are defined by 1 and 2, recurring and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. Okay, so this is very important. You perhaps are going to remember that I said to Kyle that when we diagnose someone with obsessive compulsive disorder, we want to see both of them, obsessions and compulsions. And maybe my comment was not completely accurate in the sense that the DSM is telling us that they can present either obsessions, compulsions, or both, right? But what I want you to say, and maybe that's where I didn't explain myself appropriately, is that even if the client is only presenting obsessions, the individual will have attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. And for example, that's the performing of the compulsion, okay? So let's see what is this compulsion and then how can we make sense with what I am telling you. So compulsions are defined by 1 and 2, okay? Repetitive behaviors such as hand washing, ordering, checking, or mental acts such as praying, counting, repeating words silently that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. 2, the behaviors or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dread event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent or are clearly excessive. In young children, may not be able to articulate the aims of these behavior or mental acts. So having said that, you have thoughts, intrusive ideas, intrusive images coming to your mind that they are causing you distress. They are causing you to feel anxiety and distress. And then you are going to have attempts to try to suppress that, attempts to try to ignore that. It can be either in the form of a behavioral compulsion, or it can be in the form of a mental compulsion, okay? And compulsion, you can see it as the reactions or the actions, better say, the actions that we take to try to decrease that level of anxiety and distress. So I apologize, Kyle, if maybe I didn't ask enough questions to come with a more accurate comment in that moment. And I better let you to think about this and think about what your counselor said to you, and that you come with your own opinion about if you were struggling with this or not in the way that the DSM is presenting them. Now, having said that, and what I was mentioning in the class, guys, is we want to be careful because people can have obsessive thoughts. And not because you have obsessive thoughts means that you have obsessive compulsive disorder. What's the difference between that? Well, we're going to see that the obsessions in the cluster B and C, we're going to see that these obsessions, they are really, really time consuming. They are making the life of our clients very difficult to handle, okay? So you can have obsessive thoughts when you are under a lot of stress. You can have obsessive thoughts when you are going through a crisis. You can have obsessive thoughts when things are not working well for you, but you are still able to continue with your life. And therefore, that's okay. It's part of the way that your mind is processing the situation. Now, I'm saying that's okay. That doesn't mean that it feels okay, right? It feels that it's normal to have those type of reactions when we are under a lot of stress. So B, the obsessions or compulsions are time consuming. For example, take more than an hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. In the previous DSM, in the DSM-4, they used to say that it was 2 hours, that the person was engaged in the compulsions and the obsessions at least within 2 hours a day, okay? So it seems that they are bringing that criteria, they are lowering a little bit the criteria. And then the C, the obsessive compulsive symptoms are not attributable to the psychological effects of a substance, for example, drugs or medications or other medical conditions. There are some medications that they're going to increase obsessions and compulsions. Also, people who they are high, they are using a drug and they are experiencing the effects of the drug, they may have obsessions and compulsions, but this is without that. Now, I want to tell you about, okay, so I'm going to finish this and then I'm going to tell you about a case. The onset in early adolescence or early adulthood. And then there's a lifetime prevalence of 2.5, and it's more common in women than in men. Okay, this is a book that I will suggest you to read. It's the story of a guy, David Adam, whom he had obsessive compulsive disorder, and he has a very severe obsessive compulsive disorder, okay? And then he started attending CBT treatment, and he saw a huge benefit on it. He was afraid of disease. He was afraid of getting contaminated. He was afraid of many other things. And his obsessions and compulsions were so bad that his life was very, very limited. I had other disorders that are related to OCD that the DSM-5 is telling us are body dysmorphic disorder. But I think that before starting with these disorders, I'm going to finish with the real OCD disorder. I had a client once that he was a young man. He has, I would say, what's the word that I'm looking here? A mild intellectual disability. He was able to work, he was able to cope, he was able to engage in conversations, but he was below the mean, below the average in the IQ score, okay? He was not in the extreme that you could consider him real intellectual disabled, but he was in the low standard deviation of the IQ measurement. Okay, but he was also having OCD, and his OCD was about contamination, about being dirty, and he was especially paying attention to his genitalia. For some reason, he thought that his penis, his testicles, and his anus were very, very dirty, and he was spending hours and hours and hours cleaning them. So he was going into the shower, and then he was going out of the shower 8 hours later. So he was spending 8 hours in the shower, washing constantly, especially his genitalia and his anus, because he was sure that it was dirty. And because he was so sure that it was dirty, he was having a lot of consequences. Imagine that you are spending 8 hours a day in the shower. There's no time left for anything else, right? So his life was very, very limited. Very difficult situation he was experiencing there. He was not working anymore. He was not going out with his friends anymore. He was not having any social life. He was basically in the shower all day long. And then when he was going to the bathroom, it was a very difficult experience for him because he didn't want to touch his penis. So he was in the WC, and he was pretty much with hands like this and trying to pee like that. It's not as easy as as you might imagine, especially when he wants to bring his clothes up and everything, right? He was not touching his penis. He was convinced that his penis was dirty. And then with his anus, he was cleaning so much that he was ending up bleeding constantly for the way that he was cleaning. So his life was very difficult. His life was very complicated. And what you want to do with these clients is that it's very difficult for them to stop, right? And that's why they have OCD, right? If you say to them, why do you do it? Why you just don't stop? They are not going to stop, and they are not going to come with a clear answer. They're going to say like, I don't know. I'm just afraid that it's dirty and that I can get sick, that I can get an illness, right? Or something like that. So the way that I worked with him was first, remember that we said that the therapy for these clients, I think that I have that here, is exposure and ritual prevention. And the first thing that I asked him was, what is the lowest amount of time that you have spent in the shower in the last year? And he said 6 hours. And I said, okay, how likely is that you can try to go from 8 to 6 hours during this week? Do you think that you will be able to do it? And he says, yes. So we went to 6, and then we went to 5.5, and then to 5, and then 4.5, then 4, then 3.5, then 3, then 2.5, then 2, then 1.5, and then we stop in an hour. But now he was taking a shower for an hour. That's still a lot of time, right? I was really concerned about the environmental impact that his showers were having. But now, even though it was still a lot of time, he was able to have a life. So once that we were able to reduce that amount of time, we start working with many other areas, including getting a job, including starting a social life and so on. And of course, there was a lot of concerns, fears, and preoccupations that he was having in all those areas. And the OCD was what was doing is that somehow it was protecting him of having that interaction with others, which is very bizarre, right? At the same time, we were working with CBT. It was not only this exposure and ritual prevention, but it was also working with CBT strategies. And he did good. He ended up with 1 hour, he ended up having a job, and it was a successful story. Then we stopped the meetings. It took us a lot of time. I worked with him for around 2 years, okay? Then we stopped, and then he reached out to me later on saying that some of the symptoms were coming back, that he was again spending like 3 hours or so in the shower. We work again together, and so. Why am I telling you all this? Because working with clients with OCD, that's kind of the outcome. They're going to see some relief, but then you will have to work with them again, and because the symptoms are going to come back and so on. There was this other lady that she was also afraid of contamination, but she was also afraid of harming others. So she was not driving anymore because she was afraid that by driving, she will hit someone and that person will die. And every time that she was driving, she was spending hours and hours and hours and hours and hours going back and forth, back and forth, back and forth to corroborate that she didn't kill anyone. So her life was very, very difficult as well. With her, what we did is that we work, same thing, exposure and ritual prevention and CBT. But the way that we work with exposure and ritual prevention in the driving thing was that I was with her in the car, and we were driving through the whole city. And we start in streets and avenues that there was no too many pedestrians, but then we start moving to neighborhoods where there was more pedestrians. Then we move to parking lots. Then we move to, or I should say, we drove to downtown where there's a lot of people. Then we were going to close to the schools and so on, right? And you can see the level of anxiety that these people experience is really, really a suffering, a struggle for them, right? But once that they are there and you are helping them to go in those situations that they are avoiding so much, and they see that nothing is happening, that they see that they can overcome these situations, the anxiety starts going down, the stress starts going down. We have more problems working with the contamination part, but we also work with that. She was afraid of going to public transportations, afraid to go into hospitals. She was also spending a lot of time in the shower. And the way that we worked that was going in the public transportation together. So I was with her in the train, in the city buses and so on. And then going to hospitals and spending time in the hospitals, saying hi to nurses, doctors, shaking hands with people. And after that, like, you cannot watch. You need to keep your hands like that. Now, that was previous than COVID, okay? And now I'm going to say something about COVID and OCD. And with the shower thing, what we asked, it was help of her family. And we said to the family that she was allowed to take showers for 20 minutes, but after those 20 minutes, they will knock the door and say like, 20 minutes, that's it. She also had an alarm, but we know that she was able to turn the alarm off and then she will continue. So that's why the family will go there. And if she wouldn't be out of the shower, then what the family will do, it will be to turn the hot water off, okay? So she will have only cold water and she will leave the shower. All these strategies that they might seem kind of rude, right? In reality, they are very therapeutical. But for the reason of why they are therapeutical is because the client has given us permission to engage in them. We don't do this without their permission, because if we do this without their permission, it's a traumatic experience for them, okay? Now, with this client, we have a lot of progress, but then pretty much all the symptoms, they came back and she left the treatment, which is also very common. OCD is one of the most difficult disorders to treat, guys. There's a lot of relapse, and there's a lot of cases that we are not successful with them. Beside exposure and retail prevention and the CBT, we have also pharmacological and neurosurgical treatments for them. So the pharmacological is the selective serotonin reuptake inhibitors. Remember that we talked that these are type of antidepressants, and they have shown that they are useful for clients with OCD, okay? But then there's, in very severe cases, some doctors, they like to perform cingulotomy. Cingulotomy is a surgery that it's performing the brain of the client, and they destroy the nerve cells in the cingulum, okay? It seems aggressive, and it is, of course, an aggressive. Every surgery is aggressive. But we are talking of cases where the client has no life because the OCD is so bad and because the treatment that they are receiving, it's not working, and they see this as the ultimate alternative for them. Like, no, not the ultimate, sorry, the last alternative for them, okay? All right, let's talk about these other disorders that they are OCD-related disorders. You're gonna see this in the DSM-5. In previous DSMs, OCD was part of the anxiety disorders, but now they move them and they have a new section or a individual section for OCD and OCD-related disorders. Body dysmorphic disorder. This is a disorder where the people have a dysmorphic view of their body, okay? They see, for example, they think that one arm is longer than other arm. And of course, there are some differences, but they think that they are so notorious that something is wrong with them. They can also think, for example, that in the case of ladies, that one breast is much bigger than the other breast, and then they want to have surgery because they want them to have in the same size, I will say, or that one side of her face, it's completely different than the other. And of course, these are not rational ideas. I remember a client with body dysmorphic disorder that she was thinking that one of her breasts was longer than the other one. And then she was asking doctors to have a surgery. And doctors were saying like, but your breasts are okay. They measure pretty much the same. And she was like, they are wrong. And I was telling her, have you measured yourself? And she's like, yes, I have measured myself. Have you noticed differences? No. But even though, I'm sure that they are different, right? So it's a very, very persistent idea. Hoarding disorders, as the picture that we have here, and there's a great TV show, that's why I left the link there, you can watch it. This is people that they just accumulate and accumulate and accumulate things. And once that they have accumulated so much things, their life becomes very, very difficult. They feel a lot of anxiety in throwing these things. And some of them, they live like prisoners in their houses. They cannot even leave their house because there's no room, like this firefighter, you see. And of course, they have problems with the police, with the government, because this is completely unhealthy and it's a huge risk for them. Imagine that there's a fire there, they're gonna die there, right? Trichotillomania. This is a disorder where people are taking their hair out of their body. It can be from the head, it can be from the axillary areas, it can be from the genitalia, whatever hair grows, they're gonna take them out. Now they do it in an impulsive way. And some of them, they are even surprised because suddenly they see that they have a hole in the hair, in the head, like there's no hair there. And they are like, what happened to me, right? And when people say like, well, you have been taking the hair out of your head, they are like, I have not. Yes, you have. So one of the strategies to work with these clients is to record them so they can see themselves doing that. And then they can gain in what we call illness conscious, okay, that they can be conscious of the problem. And with that conscious of the problem, they can start doing changes with that. Now, it's easier to say than to do because it is really very difficult for them. There's another extreme form of trichotillomania, which is eating them. They take the hair out and then they eat it. That is called trichotillophagia, okay? And then skin picking disorder. I want to, I'm not as familiarized with this skin picking disorder, so I want to read you something about it, okay? Give me a second, guys. Okay, I have it here. Recurrent picking of the skin that results in skin lesions. I have seen people, they have not been my clients, but people close to me. Sometimes they do this, right? Like biting their own skin, their own hands, their own fingers, and then they bleed. Or people that they can just pick, right? Start doing that constantly. Now, you need to have in mind, guys, that all these behaviors are the result of this obsessive compulsive spectrum that we were talking. Remember that the first class, we explained that there are some authors that they are against the idea of having isolated disorders, but better having like the idea of spectrums and that people can go from nothing to everything, right? Or to completely. And these are part of that spectrum, or we can see them as a part of that spectrum. We could also think about anorexia and bulimia as OCD-related disorders, because people with anorexia and bulimia, especially or both, they have the idea that they are fat, and therefore the compulsion is to stop eating, provoking vomiting, using laxatives and things like that, right? And to try to avoid gaining the weight. So one of the temptations that we can have as counselors is to work directly with the obsessions. But if we do that, we are not necessarily going to be successful with them, because the obsessions are so rooted in their mind that they are not going to give up easily. So that's why we use exposure and ritual prevention as the first way of intervening with these clients, as the main element of the treatment. Because once that they start doing things differently, once that they stop doing the compulsions or they start handling the compulsions in different ways, what happens is that the obsessions start going down, okay? All right. Let's go to the following one, which is post-traumatic stress disorder. And this is the last one, guys, so you can go and enjoy your weekend. And the DSM-5 is telling us it's exposure to actual or threatened death, serious injury, or sexual violence. That's the criteria A. Remember, guys, the DSM is giving us these criteria, and A needs to be always present. If A is not present, then we cannot diagnose, okay? Sometimes B, it's also necessarily to be present. Without B, in some disorders, we cannot diagnose. Some others criteria, they might or might not be present, and they are not necessarily, might not be necessarily for the diagnosis of the disorder, okay? But A, always. Now, criteria B, intrusion symptoms associated with the traumatic event, such as thoughts, images, memories of the event. Criteria C, persistence avoidance of stimuli associated with the event. I don't want to talk about that. I don't want to think about that. I don't want to go close to that. If I see something in the TV that reminds me of the event, I'm going to change the channel. I'm not going to watch that. I'm not going to listen news. I'm not going to, you see, they are trying to avoid things that are connected with the traumatic event that they experienced. The negative alteration in cognition and mood associated with the event. And this is very similar with the depressive clients. They're going to start talking about themselves. They're going to start blaming themselves about the situation. They're going to experience shame about the event that they had. They're going to also have changes in their mood. They can feel very depressed, sometimes very angry as well. And criteria E, alterations in arousal and reactivity associated with the event. What does this mean? Well, they're going to be in alert all the time. The levels of anxiety are going to be very high. That's why PTSD used to be an anxiety disorder as well, but now they remove them and they have their own category as well in the DSM-5, because these arousal activity alterations that they have, the levels of anxiety are really, really high, okay? And then this reactivity is that they are like all the time trying to prevent that the event happens again. They are alert. Remember that we talk about the fight, flight, and freeze response? Well, when you are in a traumatic event, that response is so intense and active that your brain learns that, and then it keeps that response active across the time, during the day, and sometimes even during the night when you are sleeping. That's why many of these clients, they have nightmares and night terrors and things like that. They really experience a lot of anxiety and nightmares, even at night, okay? Now, there's a couple of things that I want to mention here, guys. First, with criteria A, exposure to actual or threatened death, serious injury, or sexual violence. So it might be that the event really happened, occurs to the person, or it might be that the event didn't happen, but they were threatened, okay? Now, in the DSM-4, there used to be a criteria telling us that this criteria A could be even not necessarily directed to you personally, but to a loved one. So for example, I worked once with a person that he was kidnapped. It was a horrible story. He was kidnapped, and he was kidnapped by the police. That's the way that the police works in Mexico. So he left his house, he was going to his office, the police stopped him and said, like, we need to take you with a judge. And he was thinking like, I did nothing. And they say, well, you're going to explain that to the judge. We have an order for you to arrest you. And he thought, okay, I did nothing. I shouldn't be afraid of nothing. And he jumps into the police car. And then the police, instead of taking him with the judge, they took him out of the city to a warehouse where people, the kidnappers, were waiting for him. And they pay to the police to deliver him. It's such a bizarre thing, right, guys? There are things happening in other places in the world that we sometimes don't imagine. And in Mexico, the situation with the police and the violence is so difficult that people are really struggling. Anyway, so this guy was kidnapped, but his wife, she was in charge of the negotiation with the kidnappers. So she had to talk with them. She had to deliver the money. Then they asked for more money. Then she had to go and pick up her husband. And when she picked up her husband, he was completely hurt. They beat him, they punched him, he was naked, he was bleeding. She has to take him to the hospital. And then what happened with the husband was a very interesting situation. In the hospital, they treat him. Thankfully, there was no bones broken. It was only skin level, I will say. And of course, he was sore and he was in pain and so on. But next day, guess what this guy did? Next day, he woke up and he went to work to the office. And the wife was really concerned about him, and she was trying to talk with him about the situation, but he was like, I don't want to talk about it. So he was in the criteria C, right? The persistence, avoidance of stimuli associated with the event. He didn't want to talk about that. He spent a whole month pretending that nothing happened to him, working and not talking with that. Now, after that month, he started having a lot of symptoms and he was doing really, really, really bad. And that's why he ended up coming with me and I started working with him. But what happened is that the wife, she also walked through all the traumatic event, right? And then when finally she has her husband at home, he doesn't want to talk about it because he's so traumatized that he thinks that if I don't talk about this, I'm going to be better. But that's not the way that it works. So she neither had the opportunity to talk about this, to process this situation. She ended up also having PTSD symptoms. And when I saw her, she said to me like, but why I would have PTSD if it's not me, the one who was kidnapped? And I was like, seriously? So here what I'm trying to say, guys, is criteria A can be also for relatives when someone learn about this. Now, there's another way of PTSD that we call vicarious PTSD. And this is for us, counselors or police officers or firefighters and so on. People who are in touch with those who struggle with PTSD, with a traumatic event. And then by listening and being with them and so on, they develop PTSD. And this is serious, guys. If you work with PTSD clients, you're gonna listen horrible stories, and those stories sooner or later are gonna end up having an impact on you. That's why you also have to work with your own mental health, okay? All right, so 50% of population will experience at least one potentially PTSD event. This is really important, guys. Many people are gonna have traumatic or potentially traumatic events, but they are not going to develop PTSD. And that's why you want to be aware, guys. There's a trend going on with many counselors saying, oh, he has PTSD, oh, she has PTSD. And they say that because they had a difficult experience in life. Maybe they were sexually abused or physically abused, or maybe they were in a car accident, or maybe they had an assault. But having a potentially traumatic event is not the same than having PTSD, guys, okay? And look what I have been saying, potentially traumatic event. Because what is trauma? Trauma is to have a bad experience in life, or trauma is the way that we respond to that bad experience in life. You will see soldiers, they go to war, they are in the same battle, they are shooting the same people, and some of them are going to develop PTSD and some others are not going to develop PTSD. So many authors, we are saying the event is not trauma. What is trauma is the way that some people react to those events that impact negatively their well-being, their psychological well-being, and so on, okay? So don't rush your words. Don't say that because someone had a bad event, he or she or has a PTSD. If a person had a negative event, that person may overcome the situation or may suffer for that event, but don't have the symptoms that we already talked about, the PTSD. Therefore, you cannot diagnose that person as a PTSD, okay? 70 to 90% of rape victims will develop PTSD. 50% of prisoners of war, 20 to 25 earthquake and flood survivors, 15% of motor vehicle accidents, and acute stress disorder, less than 1 month. Okay, the acute stress disorder is pretty much the same than the PTSD, but it's less than a month. If a client has more than a month these symptoms, then you consider PTSD as a PTSD. Before that, you consider acute stress disorder. There are many authors, including me, saying acute stress disorder is something that we need to check. We need to talk about it because is it really a disorder or is just the natural response that some people are going to have to very unfortunate events in life? Why is that we want to give them a label and say that they have a disorder, when in reality it might be a very adaptive response to something that was really, really unfortunate and tragic in their lives? Okay, so treatments for PTSD. Exposure therapies. Here in the exposure therapies, first, it will help to extinguish association between trauma cues and fear responses. And two, it will help individual to disconfirm any symptoms, maintaining dysfunctional beliefs that have developed as a result of the trauma. What type of exposure therapy? Like what we do in phobias? No. Here we call it prolonged exposure therapy. And the author is Edna Foa. She's an authority in PTSD. She's probably the pioneer on treating PTSD scientifically. You want to go and look for her. Okay, I'm going to repeat her name, Edna Foa. Prolonged exposure therapy is the name of her therapy. Very good, evidence-based, very effective. Then cognitive restructuring. Challenge of dysfunctional beliefs like the world is a dangerous place, I'm totally incompetent, was my fault, or something that we call the just world belief. People have a tendency to think good things happen to good people and bad things happen to bad people. Therefore, if something bad happened to me, that means that I'm a bad person. I did something to deserve this. And we see this very clearly in victims of rape. They say something like, it's my fault. I shouldn't have been walking in the street by myself. I shouldn't have been dressing in that way. And we're like, no, it's not your fault. So it's not your fault. One of the things that you want to work with your clients is distinguish the difference between guilt, responsibility, and accident. And we want to always help them to see that the guilt of the traumatic event was in the hands of the perpetrator, not in the hands of the victim, or as I prefer to call them, the survivors, right? So we want to help them to do that they can see that they are not guilty of what happened to them, okay? Now, here in these cognitive restructuring treatments, I have already talked with you about cognitive processing therapy by Patricia Resig. Very, very good. I strongly suggest you to go on and get familiarized with that. Get training. There's a free training in the VA Institute. It's for free and it's awesome. It's very good. And they're going to give you educational credits and everything, okay? And they're going to give you a diploma. And it's very good. I suggest you go and do it. And then eye movement desensitization and reprocessing, or EMDR. This, the counselor asks the client to say out loud the traumatic event. And then they have a stimuli. Sometimes can be auditive stimuli, like noise from one ear to the other, and they have like earplugs. Beep, 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 beep. Sometimes are little unharmful electrical pulses that they go from one hand to the other hand, okay, and so on. And then after they have done that, they help them to have a more positive way of thinking the event. Now, there's a trend going on now with this eye movement desensitization and reprocessing therapy. I cannot say that it doesn't work, but I can neither say that it works. Because one of the problems that EMDR has is that it has copyrights. So unless that you are part of the research team of the author, or you want to pay the copyrights, you cannot do research on the effectiveness of this therapy. So many authors are saying like, well, some authors are saying like, how can we trust that this is really useful if we cannot replicate the studies, okay? But it's very popular nowadays. I personally, I will go either with the Edna Foa or with the Patricia Resig guys. All right, so I hope that this helps, guys, in your understanding of OCD and PTSD. I also hope that you enjoyed the podcast that I was suggesting you. As I said, this guy has interviews with many important figures in psychology, so I suggest you to pay attention to it, okay? And please let me know if you have any doubts, and I will see you next class. Have a good one, guys.